Welcome everyone to this channel, and today's topic is on fracture shaft of femur. So we'll be learning about the fracture shaft of femur. Uh, I'll be helping out you to get the core concept of fracture of the shaft of the femur. So whenever we talk about the fracture of the shaft of the femur, it's suppose this is your pelvis. Okay, and then you have your this is your femur. Now, whenever there is a fracture of the shaft of the femur, before understanding the fracture of the shaft of the femur, you should understand that I've already made a video on fractured neck of the femur. Fractured neck of the femur is more common to osteoporotic female. Okay, it's more common to osteoporotic female, and fractured neck of the femur, it has a much more complication of non-union, because the fractured head can actually go under a vascular necrosis and it can actually lead to non-union. Whenever we talk about intertrochanteric fracture, the major complication behind intertrochanteric fracture is it can go under malunion, and there might be a coxa-vara type of deformity. Okay, and whenever we talk about fracture of the shaft of the femur, what is the most common complication, what is the most common thing to be thought of is fat embolism syndrome. It is fat embolism syndrome. So how would you evaluate a patient who is actually having fracture shaft of the femur and you think that yes, he is having a fat embolism syndrome? So the very first thing that you will see is dyspnea, tachypnea, fever, and petechial hemorrhages. So petechial hemorrhages you can actually appreciate in the lower papillary conjunctiva, or you can see on any part of the body. Okay, very good. Now let's talk about the fracture of the shaft of the femur. So whenever we talk about the fracture of the shaft of the femur, what is the attitude? The attitude is very important for us to understand. Remember that similar to that of our hand. In our hand, what do we have here? We have our deltoid, which is responsible for abduction. So similarly, one of the abductor is attached to the your upper part of the fracture, upper part of your femur, right? So you can see in this diagram, I've made it with red color. So one of the abductor is attached to the upper part of your femur, and lower down you have your adductor attached like this. The same mechanism, suppose there's a fracture here, right here, what happens is the upper part of the femur will be displaced, which will be abducted, and the lower part will be adducted, So we will be talking we'll be talking in this regards that the attitude will be flexion, abduction, and external rotation. See this upper portion. The upper portion is on, it's going outside, like it will go outside. Okay, so I will show you with this diagram. See here, Maheshwari's diagram. So as you can see here, that the upper flexor, there's this upper flexor. Okay, there's this upper flexor, which is actually the iliopsoas muscle. Okay, and then you have the adductor. Okay, the adductor. So this adductor actually adducts it. Okay, but whenever we talk about with respect to this particular upper part, okay, the limb is going under abduction and external rotation, right? So the attitude will be FABER. So what is this attitude? Do you remember this attitude? Yes, you remember this attitude in the anterior dislocation of the hip, right? So in the anterior dislocation of the hip, the attitude is flexion, abduction, and external rotation. It is similar. It is on contrary, on the posterior dislocation of the hip, you will have flexion, adduction, and internal rotation. Remember, posterior dislocation of hip is more common to the dashboard injury. So whenever we talk about dashboard injury, you need to understand about the posterior dislocation of the hip. Okay, very good. Now let's move on to the another thing that we need to understand. I already told you that fracture of the shaft of the femur, there's high chances of fat embolism syndrome, right? What is the other most common complication is blood loss. And can you tell me the other fracture where there is severe blood loss? Yes, it is the fracture of the pelvis. So fracture of the pelvis also consists of blood loss, and that blood loss is severe. It's so severe. It's very much severe. Okay. So fracture of the shaft of the femur, you need to understand, one is blood loss. The second one is, yes, it is problem with your body, fat embolism syndrome. Okay. Now you need to understand that there is a classification for shaft of the femur fracture. It is not given in Maheshwari, okay? It is not given in Maheshwari, but it's better you understand, you know the classification, and that classification name is Winquist and Hansen's classification. Winquist and Hansen's classification. And I will help you out to understand this Winquist and Hansen's classification, okay? So it has four part, okay? Four part: type 1, type 2, type 3, and type 4. So type 4 is a severely communicated fracture. Of course, type 4 is a severe communicated fracture. Moreover, in every classification, whether that be a Kleil's classification or that be a Schatzker's classification, right? So the more in the classification, the as you go towards the end point or the most severe prospectus, the most common fracture, these fracture will be really communicated. The same mechanism is here also, that the Winquist and Hansen's classification type 4, it refers to a severely communicated fracture. Okay, now what do you mean by type 1, type 2, and type 3? See, type 1, type 2, and type 3, the type on this, the least common one, I'm sorry, the least common, I mean to say the least injurious or the least dangerous one. What happens to the least dangerous one? There is simply a hairline fracture, small fracture, okay, the tiny cortical fracture, simple, right? A simple tiny fracture is taken as type 1. Type 2 means it's a butterfly segment. There's a butterfly segment with more than 50% of the fracture which is attached to the cortex. What does that mean? See here. Suppose this is a fracture, right? Suppose there is a shaft fracture. Suppose there is a fracture and the fracture site is attached. It is attached to your shaft in this way. Second, I would like to give an example. Second one is actually going distal like this, okay? So this is just for understanding purpose, okay? So understand this type 2 and type 3, which is much more in continuity with the cortex. That means which is much more in conjugation with the cortex, it is type 2, right? Type 3 is far apart. It has been, it is not actually kissing the cortex, if you can understand in this way. If it's really kissing the cortex, more than 50% kissing, this was just for understanding, okay? But you need to say that more than 50% contact with the cortex, not kissing word, okay? More than 50% contact with the cortex, it is actually type 2, okay? In type 3, you need to understand that butterfly segment, which is with less than 50% attachment with the major cortex. And type 4 means it's a severely communicated fracture, okay? So we have understood this about. And how will the patient present with? Of course, the patient will present with pain. If he has associated fat embolism syndrome, I will be making a video on complication of fracture. Stay tuned for it. So if he presents with fat embolism syndrome, he'll have all the features of fat embolism syndrome. And sometimes there can be actually presence of fat globules in urine also in the case of fat embolism syndrome. I'll be talking about that all in the case of complication fracture. So how are you going to treat this person? How are you going to treat this person who is having fracture shaft of femur? So it's very easy, okay? Fracture shaft of femur, it's very easy. So what are you going to do? What you're going to do is you are going to manage on the basis of age. For example, if the person is a child, if it's a child, and then you need to go for a conservative management, you can either go for a hip spica or you can go for a gallows traction. So you can go for a hip spica. I will show you the pictures, don't worry, okay? Or you can go for a gallows traction. So what happens in the gallows traction? In the gallows traction, the hip as well as the legs, okay, both are raised and it's tied to one upper point, okay? It's tied to one upper point. So there will be counter traction and traction. The traction is provided by the upward pull and the counter traction is provided by the I'm sorry. The counter traction is provided by the weight of the body. Okay, so the upward pull is actually by the upward pull, okay, and the counter traction is provided by the weight of the body. That is known as gallows traction. Similarly, the next actually splint that we can use is a hip spica. It's 1.5 hip spica. I'm showing you the picture now. See, this is a 1.5 hip spica. What you do is you cover whole the hip, okay, from hip to knee to ankle, and along with that you cover the half portion of the other unaffected part, okay, and you have to keep like this to the patient. Time duration, I'll tell you right now, don't worry about it, okay. Time duration also I'll tell you. Now if it's an adult, what you're going to do in case of adult, if you want to go for a conservative management, you can go for a Thomas splint, okay, Thomas splint. And the definitive management, if you want early weight bearing, if there is a severely complicated fracture, if there's associated nerve damage, if there's associated arterial damage, you have to go for open reduction internal fixation. So how will you do this? You can go for either plate and screw if you have to go for open reduction internal fixation. If there is no severe communication and you want to use the nail and you want to go, then you can go for close reduction internal fixation with IMIL, intramedullary interlocking nailing system, okay. Now you need to understand about the treatment modality, the conservative treatment modality. Whenever we talk about the treatment modality, the Thomas splint, what we used was actually, it was a skeleton traction, and that skeleton traction is usually used in the adults, okay. And in the skeleton traction, you'll use Steinmann spin, okay. You'll use Steinmann spin. So what is the Steinmann spin? Steinmann spin means it's like a pin, like this. You can see this, okay. It's like a pin. It's inserted inside your distal part of your. It's inserted inside and it's pulled, okay. It's inserted inside and it's pulled. So it's inserted towards your distal part of your femur, and then it's pulled, okay. It's pulled. So when you pull it, there is actually a proper reduction. So what is our basic concept is, suppose there is impaction like this, so when you pull it, there'll be reduction like this, right? And we want to stabilize this reduced fragment with the help of splint, okay. Now what we need to do is, if the child is less than 12 years of age, then we have to use gallows traction, okay. Less than 12 kg, we'll go for a gallows traction, okay. But if the child is more than 12 kg, we have to go for Russell's traction, okay. More than 12 kg, Russell's traction. Less than 12 kg, you'll go for gallows traction, okay. And in children, sometimes we can also use hip spica, okay. If we are using gallows traction, we use it for 2 weeks, okay. So you write it down, gallows traction, you use it for 2 weeks. And Russell's traction, you use it for 3 weeks, okay. So in children, what are the modalities? Or you can also go for hip spica for 4 weeks. Simple. For remembering purpose, it's very easy. Gallows traction, Russell's traction, hip spica. Gallows traction less than 12 kg, Russell's traction more than 12 kg, and hip spica, okay. Hip spica, you can use it in small children who are not able to walk, okay, because in them the osteoplastic activity is so high that healing is very rapid, and those children, they don't need to go and they can't actually walk, no. But in the case of adults, to put in a hip spica, you need to actually put a hole in the area of perineum so that you can go for toilet. You can do toilet in his bed. That will again lead to bed sores, a lot of complications. So for adult purpose, if you need to go for a conservative management, you have to go for a Thomas splint. But if in case it's a condition that you have to actually operate, then you just operate on the patient, okay. And next thing that you need to remember is, skeleton traction is used with Steinmann spin or K-wire in the case of adults, okay, and it's stabilized by Thomas splint, okay. And remember, in children, is it only the management is only conservative with gallows traction, with Russell's traction, or with hip spica? No. If the children is more than 10 years, it's very difficult to stabilize a child into a bed, okay, and put a traction. So it's okay that you can go for a TENS, okay. So what is TENS? TENS. TENS means titanium elastic nailing system, okay, nailing system. Okay, so open reduction internal fixation can be done in the case of, I already told you, severely communicated fracture, type 4 Winquist and Hansen's classification. Close reduction can be done by interlocking IMIL, okay, intermedullary interlocking nailing system. See, IMIL is very good than plate and screws, because plate and screws, they actually interfere with the fracture hematoma. IMIL will not interfere with the fracture hematoma. And IMIL is actually a load sharing device. So what happens is there'll be a proper healing, okay, but plate and screws are actually weight bearing device, okay, so they bear the weight, okay. So let me show you some of the pictures which is relevant. So you can see here, fracture the neck of the femur, okay. I already told you about this one. See, Thomas splint, Steinman splint attached to the upper end of the tibia. I told you the distal femur. Distal femur means upper end of the tibia, okay. Distal part, Steinman splint is passed, and then you just give us skeleton traction, and 1.5 hip spike can be used. And if you want to go for a closed reduction, you can go for IMIL, okay, IMIL, right? And what are the complications? The complications is C. Gallows traction is C, this picture. The hip is lifted off the bed, and of course the upper bed's lifted. So here this provides you the traction, and the body weight of the body provides a counter traction, okay. And if it's I told you gallows traction and Russell's traction. Gallows traction less than 12 kg, or you can write from birth to 2 years. Russell's traction is more than 12 kgs, okay. And if in case that is also not possible, you can go for 10s, okay. From 2 years to 16 years, you can go for 10s. Usually we do not prefer a lot of conservative management right now, because everyone are in hurry to get treatment, right? So they want early weight bearing, so it's better you go for 10s in the case of children, okay. They can be non-union, malunion, they can be infection. The major one you should not miss is fat embolism syndrome. The other one you should never miss is, yes, it is severe hemorrhage, okay, severe blood loss leading to shock, okay. And other can also be there, like sciatic nerve injuries or femoral artery injury, okay. So with this we complete the fracture of the shaft of femur. Thank you.